Right, hello everyone. Welcome to the very first ultrasound journal Win Focus podcast. So, my name is Adrian Wong. I'm a consultant in intensive care medicine at King's College Hospital, and I am joined by some very good friends and esteemed panel. First of all, I am joined by Professor Francesco Corradi, who is the editor-in-chief of the Ultrasound Journal, which is the Win Focus journal. But for our first podcast, we are joined by a colleague all the way from Brazil, Dr. Rafael Melo, and the paper that we will be discussing and his piece of work is titled Venous Access Ultrasound Score Association with Acute Kidney Injury in Critically Ill Patients, a systematic review and meta-analysis of observational studies. For those of us who do ultrasound and fluids, very topical. But first, I'll let Dr. Melo introduce himself. Dr. Melo, over to you.
My name is Rafael Melo. I am intensive care physician from Brazil. I work at Hospital Israelita Albert Einstein and also a Palcos lover.
Welcome, and that's why we have you here. First of all, congratulations on the paper. We are going to have an opportunity to discuss it in great detail, but for our listeners, why don't you give us an overview about the paper itself?
So, we know today how important it is to identify venous congestions to hemodynamic and fluid management in the critically ill patients. Venous congestion ultrasound score is a promising ultrasound parameter that allows us to access venous congestion at bedside, and maybe more accurately than CVP. However, it was developed and validated only in cardiac surgery patients. Therefore, its utility in the critically ill patients remains unclear. To fill this gap, we did a systematic review and meta-analysis looking at how venous congestion, measured by VEXUS score, correlates with acute kidney injury in the general critically ill population. The results were pretty interesting, although in my opinion expected. Overall, patients with VEXUS score equal to or greater than 2 were more likely to develop acute kidney injury, especially those who had undergone cardiac surgery. In that group, the odds were almost 4 times higher. We didn't find, although, a significant association between venous congestions and overall mortality. So I think this is the summary of our results.
Okay, thank you very much for that. I'm going to go to Francesco now because as editor-in-chief, I'm sure lots of papers cross your desk and you've got to review them, so on and so forth. So, Francesco, from your perspective, why is this paper important? Why is it important to get this message out there?
So, from the editorial perspective, let me first congratulate with the authors and with Raphael on addressing such important and timely topic for our journal. The investigation into the association between the VEXUS and the AKI in the critically ill patient is at great clinical relevance up to now, given the growing interest in POCUS as a tool for assess venous congestion in everyday increasing number of ICU settings. So I want to thank you for this submission. Concerning the manuscript, I have to say that I deeply appreciate the motivation of the authors concerning these tricky topics and the balanced conclusion, suggesting cautiousness in the application of VEXUS in the general ICU population, mainly due to the lack of strong body of evidence correlating VEXUS with AKI in general ICU patients. Indeed, in the manuscript, a subgroup analysis of non-cardiac surgery patients found no correlation between VEXUS score and the incidence of AKI. And this is very important. Maybe due to insufficient statistical power analysis of the studies, maybe yes, or because alternative mechanisms of AKI in the general ICU populations, different from cardiotomic patients or patients with heart failure, such, for example, sepsis, nephrotoxicity, or a complex and tight organ crosstalk may play a major role compared with venous congestion by itself. So, from my perspective, the present study is important because provides a very important insights, especially in its focus on the predictive role of VEXUS in a mixed heterogeneous ICU population, thus expanding the discussion and the clinical debate of venous congestion well beyond the traditional scenario represented by cardiac or cardiac surgery patients. Furthermore, there was no association between venous congestion and mortalities in the present meta-analysis. And these findings, from my perspective, should be interpreted cautiously, considering the heterogeneity of the population, meaning that, as correctly stated in the conclusion of the studies, additional studies and follow-ups are needed to assess whether Nexus-based management strategies can have a deep clinical impact and, more importantly, improve outcomes because they may be beneficial or not. And we have to be sure to do not harm our patients. So thank you, Rafael.
Great stuff, Francesco. Raphael, we had a conversation before we came online, and all of us share this passion for fluid management, ultrasound, etc. We all have our own inherent biases when we look at the literature, etc. So when I'm going to ask you now then, when you did this piece of work, and again, it's a monstrous piece of work, thank you for doing it. What do you think are the key lessons that you would like to share, both from your viewpoint as a researcher, but I think more importantly, and Francesco talked about it, the clinical side of things? What would you say to clinicians that was surprising, unsurprising when you delved into this piece of work?
Tricky question, because I think this article is not the end. I mean, it's just the beginning to raise awareness about how we have to study more venous congestions and tools to access venous congestions at the bedside. So I think with this paper, we are all about finding non-invasive ways to access patients, right? And VEXUS gives us a structured, easy-to-use method to evaluate venous congestion at bedside. We all have seen how tricky it is to strike that balance between giving enough fluids and avoiding fluid overload. So VEXUS could help us identify which patients are already struggling with congestion and tailor interventions. And maybe with this paper that have gathered all the evidence you have until now, we know that you can apply it in other populations different from cardiac surgery patients, but interpreted with cautious, because even if I found venous congestions, we have already talked about this before the podcast, but what does it mean? It means I have to do something. I don't know. I mean, VEXUS don't tell me that. Just tell me that you have amount of pressure and overload on the venous size of hemodynamics. So what you have to do with this, we don't know. So you need more studies, prospective and maybe randomized trials, studying if VEXUS-based management could improve outcomes, and if I have to really do interventions if I found a high VEXUS. I think it's
a very interesting point. So, Francesco, I'm going to ask you to put your clinician hat on now, put your the research side of things. Now that you've read the paper, it comes out, will it change your practice? What would you do? How would you how would you tell your residents about it? What do you think?
Okay, so I think that we may apply a VEXUS approach depending on the setting. For example, I like always to start from pathophysiology. And
I agree.
up to
100%
now,
agree with you.
Up to now, I think that the main question is congestion, or if you prefer, the pulsatility or the increased pathological pulsatility on the venous side of the circulation is mainly due to an increase in systemic filling pressure or mainly due to high heart pressures. And I think that in the cardiotonic patients or in patients facing with acute heart failure, probably irrespective of the cause, the increased high heart pressures plays a major role. So probably I'm allowed to act and do something. Reduce volume, reduce pressures, reduce PEEP, or to be as protective as possible if the patient is on mechanical ventilation. On the contrary, if I apply the Vexus approach, and I suggest too, on a patient experiencing septic shock, I think that up to now, the higher the pulsatility was the patient's. But I need to understand much more the correct behavior. And I'm not sure we can directly translate our findings into a change in the clinical practice. Not for sure, from my perspective, managing only fluids.
I think you hit the nail on the head. I think, again, an observation on my part and shared experience for what's happening in my patch, if you will. Probably the two most important take-home messages I took from this one, from the paper that Raphael and team put together, is one, actually, the evidence base for Vexus in terms of when it works, when it doesn't work, is rather limited. That's the first thing to say about it. And there is definitely a need to expand the research side of things, to have more trials and more studies. The second thing about the paper and highlights my patch is that I think it is not so much the principles of Vexus, i.e. putting a pulse wave Doppler over the veins to assess the flow, etc. That's not the problem. I think the misinterpretation of what Vexus, elevated Vexus score means is variable. So some people, it almost became, when it first came out, a high Vexus score equals fluid overload. That's a gross oversimplification of what it means. But that seems to be the message people were taking away from that first paper. Raphael, your thoughts on that?
Yes, I endorse this affirmative because we see this a lot here in Brazil. People associating Vexus with hypervolemia. We know that this is not true. I mean, higher Vexus, an elevated Vexus means that the afterload, if I can say that, the afterload of the venous size of hemodynamic compartment is high. So the afterload could be high because of pulmonary embolism, because of right ventricular dysfunction, or even a thrombus inside the venous cava. So, I mean, there's a lot of stuff and pathologies that can rise the venous size pressure or the venous side pressure. So people are misunderstanding what Vexus bring to us.
Okay, so as a way of summing up this podcast, then I'm going to put both of you on the spot. I'm going to ask you, now that this paper is out, so what now? So what now from a research perspective? So what now from a clinical perspective? If you read the paper and you had to go to work tomorrow, would it change your practice? Should it change your practice? I'm going to go to Raphael first, and then I'll go to Francesco. So what now from research? So what now from a clinical perspective?
I think this paper isn't the final word. I mean, it's just the beginning of understanding how Vexus works and how can we use it and apply it. I mean, with all its limitations and utilities. I mean, Vexus fits into a broader picture of critical care, and maybe future studies analyzing the impact of Vexus-based fluid management could clarify to us the real impact and utility of this score in clinical setting. I mean, and of course, it will for sure depending on the population you are studying. I mean, the cardiac surgery patients, we have already seen that Vexus is a very, very good tool to predict acute kidney injury, but in acute decompensated heart failure, and the sepsis patients. We have to study in these populations and to find a more conclusive outcome and reason to really accomplish this objective and to use Vexus in our clinical practice, I mean.
Okay, thank you very much, Rafael. Francesco, thoughts?
So, cautiousness and more research is warranted and needed, especially in contexts that are different from cardiac surgery patients, or nephrologic patients with fluid overload, because for sure, in some context where I know the patient is overloaded, maybe I can rely on the Vexus degrees in order to monitor or to target my treatments. But in most of the other contexts we are facing with in the critical care, we have to be very context specific. I like always to remember from my clinical practice an asthmatic state that in young male without heart failure that required neuromuscular paralysis and horotracheal intubation, so without increased intrathoracic pressures and without fluid overload, but facing with a huge adrenergic storm. And his planned circulation was everything pulsatile. What it means, I don't know, but maybe it means compared with another asthmatic states. But for sure, try to think different, because in an asthmatic state, not fluid overload or the treatment of decreasing fluids or performing furosemide was not the proper treatment. So physiology is much more complex than this, and congestion did not equals to fluid overload. This is the main message from my clinical point of view.
No, I 100% agree with that, and that's a very nice take-home message to end this podcast. I think one of the important things that this paper and other papers like it that have been published in the literature is that at least we're talking about it. You know, more research is coming. We're still finding our feet in terms of what it means, what we should do about it, and ultimately, this is just a tool. And with the tool, without allied to the correct management strategy, this is not going to improve patient outcome, which is ultimately what we're all aiming to do. So I'll close off by thanking Professor Corradi for joining us, Dr. Rafa Mello for joining us. Thank you so much for the piece of work, and I look forward to hearing more from your work and research in the future. Thank you very much, everyone.
Thank you.
It's my pleasure. It was a great honor, and thank you for hearing me and give me the opportunity to talk a little bit about this article that I really enjoyed to did.
Dr. Mello, to the next. We are waiting your next submission.
I'm looking forward.